Good morning and welcome to the lecture on deviation in air exchange. We are going to be discussing bronchitis, pneumonia, and I think there's a little bit of emphysema in here as well. When you're looking at these three situations, you're thinking of that triad associated with COPD. Of course, the objectives of this is in alterations of air exchange is to interpret respiratory assessment findings to derive an actual or potential nursing diagnosis, to analyze the pathophysiological changes that occur in response to exchange of air, list expected outcomes for actual or potential air exchange problems, select nursing interventions that are evidence-based, and please make sure you're always using interventions that are evidence-based to restore and to rehabilitate the patient, differentiate between pharmacological agents that include actions and their responsibilities, use expected outcomes to evaluate the effectiveness of nursing interventions, and apply teaching learning principles to assist patients in drug management, lifestyle changes, and pulmonary exercises. And of course, with the NCLEX blueprint, we're looking at safety and effective care environments, health promotion and maintenance, psychosocial integrity, and physiological integrity. Acute bronchitis is inflammation of the mucous membranes in the bronchial tree that happens rapidly. It's not like chronic bronchitis where people have chronic inflammatory response in the bronchial tree. This is usually brought about by some type of viral or some type of bacterial infection. The inflammation produces a large amount of mucus. At first it affects the nose, the sinuses, the throat, and then it spreads through the lung. And it's usually secondary to a bacterial infection. People who are at risk for acute bronchitis include the elderly, infants, young children, people with heart and lung disease, and those people that are around smokers or those people that are smokers. The following makes bronchitis worse: air pollution, allergies, occupations such as coal mining, textiles. And that's funny that they should only use that, but don't forget people who use strong chemical cleaners, people who do nail filing and are exposed to toxins from nail polishes, so people who do close work with chemicals. The pathophysiology of bronchitis includes the inflamed mucous membranes of the bronchial tree, which produces a very, very thickened sputum. This is usually in response to an infection brought about by strep, pneumoniae, Haemophilus, which is just your flu, mycoplasma pneumonia. Can be fungal in its nature. The problem is you have to identify the culture of the bacterium through a sputum sample, and also in an environment where a person is constantly exposed to irritants to identify those irritants. Clinical manifestations include that hacking, irritating cough, a person sitting next to you at times. That if the mucus is a yellow, green, it's usually associated with a bacterial infection. There's a lot of chest discomfort associated with that coughing, and oftentimes, because of the persistence of that coughing, people will develop pleurisy. Fever, chills, night sweats, headaches, and general malaise are often very common symptoms. As the infection process progresses, many of the symptoms include shortness of breath, when a person is active, stridor, expiratory wheezes, and purulent sputum. Shortness of breath with activity could include walking across the floor. And when you think about a nursing diagnosis, you're thinking about an ineffective airway clearance. It makes sense. You're blocked up constantly because you have that thickened mucus secretion. So ineffective airway clearance related to excessive thickened mucus secretion. And you can give it as evidenced by in there, and of course it's by constant coughing with productive secretions. Nursing interventions include trying to keep the patient at home as much as possible, encourage the mobilization of those secretions through ambulation, effective coughing, and deep breathing. I once thought that chest PT was one of the interventions that was also used, but evidence-based practice might suggest that walking is far more curative than chest PT. Treat symptoms of fever and cough, trying to keep as comfortable as possible, although not using a cough suppressant that doesn't include an expectorant. You must have an expectorant in your cough syrup. You don't want to stop a cough. Oftentimes they use codeine in cough syrups, which will necessarily suppress a cough, but that's usually when the person is so fatigued that they need to get rest. Ensure adequate fluid intake to liquefy those secretions and to prevent dehydration caused by fever and tachypnea. Avoid overexertion. This is not the time to be running. This is not the time to be overexerting oneself. It's time to try to chill out, practice on really good deep breaths and mobilization, a good walk. If taking antibiotics for the infection, it is important that you teach the patient to complete the full prescription. Nursing interventions include advise the patient that the dry cough may persist after bronchitis because of the irritation in the airways. And I'm talking about maybe almost 2 months afterwards, bronchitis could persist with that nasty cough. Encourage avoiding bronchial irritants, including smoking, if at all possible, smoking cessation, if at all possible. Avoid being in situations where there's excess dust. My house. A good diet to facilitate recovery, maybe a little bit more of the protein, but definitely a lot more fluid. Caution the patient on using over-the-counter cough suppressants, antihistamines, and decongestants, which may cause drying and retention of secretions. And oftentimes those antihistamines cause what's called a rebound, where all of a sudden they don't work, and as a matter of fact, they make the situation far worse. Pneumonia. This is where the gas exchange is necessarily impeded because the alveolar capsules are kind of embedded in fluid. Pneumonia is an inflammation of the lung. The infection may be caused by bacteria, fungi, and viruses. Community-acquired pneumonia is pneumonia in people who haven't been in a hospital or any other healthcare facility. Hospital-acquired pneumonia, nosocomial sometimes without a cause necessarily, is an infection of the lungs that occurs during a hospital stay. They say that the minute you walk into a hospital, you fill your lungs up with gram-negative bacilli, but it's really the immune system in a patient who is weakened that can necessarily pick up a hospital-acquired pneumonia. Ventilator-assisted pneumonia is a type of hospital-acquired pneumonia that develops 48 hours after an ET intubation. That's why they kind of shy away from those ventilators because it's so harsh on the lungs, and sometimes you're forcing bacteria into the lungs. And then there's also healthcare associated pneumonias, which is necessarily after acquiring healthcare maybe outside of a hospital setting, but into the community a little bit more. That healthcare assisted pneumonia is a non-hospitalized pneumonia occurring in a patient who has extensive healthcare contact with one or more of the following. They've been in the hospital for less than 2 days within 90 days of an infection. They are a resident of a long-term care facility, nursing home, rehab center. They're on antibiotic therapy, chemotherapy, or wound care within 30 days of infection. Sometimes the patient could be on hemodialysis. Home infusion therapy or home wound care could necessarily reduce the immune response, causing the potential for pneumonias. Family members with infection due to multi-drug resistant bacteria, which are very, very difficult to treat. So community-acquired pneumonias include strep pneumonia, which is a major bacterial cause, Haemophilus influenza, Legionnaire's disease, Legionnaire pneumonella, mycoplasma pneumonia, and viruses. Sorry, that's spelled incorrectly. Hospital-acquired could include MRSA, and that's why we try to keep people on contact isolation, or we try to keep them maybe cohorted with other MRSA patients. Staph aureus is another hospital-acquired bacterium. Klebsiella pneumonia and Pseudomonas is some of those that are very, very common, frequent to hospital systems. Please look at the locations of the fluid buildup. You have both normal cross-sectional descriptors of the alveolar passages. So a normal one shows it's nice and clear. The potential for air exchange or gas exchange is great, but when that fluid is in that sac, there is no gas exchange that could happen. Also looking at different areas where you can see there's pneumonia in alveoli. In all of those pictures, A, B, C, and D, you can see before and afters. Please understand the pathophysiology of pneumonia, because pathogens are able to get into the upper respiratory tract and they penetrate the airway through mucus and they multiply in the alveolar spaces. Unfortunately, the alveolar spaces is a great environment for bacterium viruses to grow. Pathogens can be from bloodborne organisms that enter into the pulmonary circulation and are trapped in the pulmonary capillary bed. They're colonized in the alveoli, and then there's an inflammatory response. Cough, sneeze, and do whatever, you're contaminating the vapors that emit from the sneeze and cough. Pneumonia is the infection of the lung that may be caused by bacteria, viruses, or fungi. The infection causes the air sac to become inflamed and fill up with fluid or pus, and it makes it very hard for oxygen you breathe to get into your bloodstream. You may be doing the breathing, but it's not having an effect. The inflammation that is caused damages the membranes of the bronchioles and alveoli. The alveoli fills with fluid and thickens in the alveolar wall. It causes scar tissue formation. The fluid causes edema, and the alveoli facilitate the movement of the microorganism to other alveoli, and it almost is like a beautiful environment for stuff to grow in. It's warm, it's moist, and it's got a great food source. And the alveoli protects the microorganism from its own phagocytosis. Pneumonia affects both the diffusion and ventilation. It causes hypoventilation, and it's a ventilation-perfusion mismatch. You're not getting the oxygen-carrying ability of the blood as a result. You have inflammation of the alveoli, and you have exudate that interferes with that exchange. The white blood cell, which is those neutrophils, migrate to the alveoli and fill that air space in there. The lung has decreased ventilation because of secretions in the alveoli, the bronchi, and because of bronchospasms. Now you are beginning to develop arterial hypoxemia. The blood passes through the capillary bed of the alveoli and leaves without any O2. Seen again in that picture with increased exudate in the alveolar passageways. Lobular pneumonia is a form of pneumonia characterized by inflammatory exudate within the intra-alveolar space, resulting in consolidation that affects a large and continuous area of a lobe in the lung. A bronchial pneumonia is a type of pneumonia that causes inflammation in the alveoli. Someone with bronchial pneumonia may have trouble breathing because the airways are constricted. And when you have aspiration pneumonia, a lung infection develops after you aspirate or inhale food or liquid or vomitus into your lungs. You may also aspirate food or liquid from your stomach that backs up into your esophagus, and people who do have reflux disorder can at times develop aspiration pneumonia. Risks for pneumonia, of course, include immunosuppression, advanced age, chronic disease process, including COPD, depressed cough response, and don't forget strokes, neurological disorders, respiratory depression caused by medications, depressants, immobility, poor nutrition, difficulty swallowing, conditions that produce mucus or interfere with lung damage. Unfortunately, targets are nursing home residents, somebody having a viral infection or the flu, having no vaccinations, smoking sometimes because of the muscular loss associated with being drunk, altered level of consciousness, aspirations and endotracheal intubations, and of course poor oral care. Don't forget, gram-negative bacilli is located underneath the jawline where the root of the tooth is. When a tooth is loose and it gets shifted off to one side, somebody aspirates the product of whatever is in their mouth, and unfortunately they could develop a very, very strong gram-negative pneumonia. Clinical manifestations of pneumonia could, of course, vary from different types of organisms. Sudden onset of chills, rapid rising fever, pleuritic chest pain, tachypnea and bradycardia. Nasal congestion, sore throat. Signs and symptoms are gradual and nonspecific, which may include headache, low-grade fever, pleuritic pain, and just fatigue. How about orthopnea, tachypnea, cough? You may cough greenish yellow mucus, and sometimes it's a dry, stupid hacking cough. Decreased breath sounds, Fine crackles, rhonchi. Look for a rapid bounding pulse, dyspnea, cyanosis, hypoxemia, anxiety, confusion, especially in the elderly, excess sweating and clammy skin, headache, loss of appetite, low energy and fatigue, sharp or stabbing chest pains that get worse when breathing deeply. Always assess for somebody who to see if they've had a recent cold or flu. Oftentimes, secondary bacteria pneumonias do develop. Any chronic illness history. Their age. What kind of medications are they on? Are they a smoker? What type of work do they do? Any family members with the flu? Any recent vaccinations? Any allergies? Any psychosocial information, which includes poverty, being in situations, in overcrowded situations, and not having nutritional sustenance. Assess for pain, fatigue, chills, shortness of breath, anxiety, anorexia. You're not going to be able to eat if you can't breathe. Chest muscle weakness. Objective signs and symptoms, general appearance. Don't forget your general survey. Vital signs. Auscultate the lungs. See if a person is using accessory muscles. Check for the pulse ox. Look at the level of consciousness and watch and gauge for the level of consciousness. Skin, pallor. Any cough patterns. I cough more when I lay down. I cough more in the evening. And what's going on with their sputum, its color. Again, monitor with the pulse ox, a CBC with differential. You want to make sure you're doing a sputum, CNS, and gram stain, usually done first thing in the morning, usually up before a person does eat. You want to make sure you're doing blood cultures, chest x-ray, PA and lateral, meaning both sides of it and front and back. Blood cultures, electrolytes, blood gases, although you won't see blood gases done that frequently, but you may see CO2 levels, a CT of the chest, usually not necessary, and a visualization through a bronchoscopy, although potentially not that prevalent unless there are some other associated complications. And by now you probably have seen pulse oxes. They are measuring arterial oxygen saturation. You can use the probe on the ears, the fingers, and the toes, and there are different types in different facilities. Intermittent or continuous monitoring, especially if a person is on a vent, and nail polish can necessarily interfere with the reading of a pulse ox. Sputum specimens are done to diagnose, evaluate, and to treat. You want to be able to identify that organism and any abnormal cells that are in there. You want to make sure you're doing a culture. You want to see what's growing, and a sensitivity, and sensitivity being what antibiotic would be appropriate for this organism. And gram stains are a staining technique for identification of the bacterium. And that's when you get that violet stain, which is a red dye, and you get the blue dye. And with the cell wall will determine the particular type of bacteria, be it gram negative or gram positive. Pictured here is a chest x-ray, but normally you'll find a 2 view that will be done on the floor if it has to be done at the patient's bedside. But the PA is that posterior view, and anterior, that's the PA, and then the lateral are on both sides. ABGs to check arterial blood gases, and that's when you're usually looking at that pH, you're looking at CO2 levels, you're looking at O2 levels arterially. I think I made a word up. Not done all that much, but a lot of times what you'll see are CO2 levels, which is just done through venous CO2 levels. And that's just making sure that there is a gas exchange and the ability to have that gas exchange. And a bronchoscopy can be done, which is a tube that's placed into the bronchioles and could go down either tree of the bronchioles, and kind of a nuisance, but it is definitive, and it could show if there's any pockets or what type of pneumonia the person may have. Pneumonia considerations must include vaccinations, antibiotics, and of course with the elderly, who are always getting pneumonia vaccines. Please make sure when you're talking about care plans that are having considerations, always talk to the patient about having vaccinations, completing antibiotic therapy. Treatments would of course include antibiotics, which must be completed, antipyretics, that's your Tylenol, something for that fever, Antitussive, something to allow for to stop coughing, and expectorants, which allows you to bring secretions up. When you have an expectorant included in your antitussive, make sure that you are drinking a lot of fluid with it. Complications could include a collapsed lung. Sometimes atelectasis is what it's referred to. Unfortunately, that could happen spontaneously because of excessive coughing sometimes. Bacteremia, septicemia, and sepsis. Pleural effusion, meaning that the lung is rubbing against the pleural sac. Respiratory failure. Pleurisy, which is an irritation of that respiratory sac. And confusion. There's another thing, complications with medications. Please don't forget, when you are giving somebody excessive amounts of antitussives, those work on the neurological system to try to stop the stimulation of the cough response. Please avoid giving those types of medications for people who have Parkinson's disease. Neurological in their nature can interfere with Parkinson's treatment. Nursing diagnosis, respiratory, ineffective airway clearance, can't get the sputum out. Impaired gas exchange, you are not getting the alveolar exchange of gases. Ineffective breathing patterns, are you using accessory muscles? Other associated diagnoses include activity intolerance, anxiety and fear, altered thought process, impaired verbal communication, fluid volume deficit, hyperthermia, hey, that fever, acute pain, disturbed sleep patterns, I cough too much at night, altered nutrition, less than that's required of the body, can't eat when you're sick and you can't breathe, and a knowledge deficit, not knowing how and when to take medications, how to avoid irritants. The goal is to support optimum respiratory function, to rest and decrease metabolic and O2 needs, maintain fluid volumes, maintain adequate nutrition, understand the treatment protocol and preventative measures. There's nothing worse than a patient going home and not knowing how to follow up on their care. And always look for the goal of an absence of complications. Expected outcomes, you want a patent airway. You want to make sure that you have a pulse ox above 96. You want to make sure your ABGs are back to normal again and you have an effective cough. You're maintaining your vital signs. Your sputum is coming out. It could be thin, watery, or clear. Expectorated means that it is coming up and is being coughed out. There's an absence of all complications. You're able to rest. There's no pain. There's no anxiety. And you're achieving proper nourishment. Nursing interventions include give fluids, humidify the air, encourage and assist patients in effective coughing, instruct patients on how to use that incentive spirometer. Please make sure you know how to use that incentive spirometer, that you are not exhaling into it, you are inhaling into it. You're making an effort to get a good deep inhalation. Administer chest PT, but really walking is better according to evidence-based practice. Position changes are necessary, postural drainage. O2 therapy could be very helpful and provide comfort, provide rest. You want to make sure you're keeping in a semi-Fowler's position, heads partially up, provide good nutrition, educate the patient and the family, administer medications as necessary, and any complementary therapies which might be necessary, like humidified air, maybe oils, maybe menthol vapors. Pleurisy could be minor in its nature. It could be because you got a baseball thrown into your chest. You have a football tackle. But it's an inflammation of both the visceral and the parietal pleural layers of the lung. It may develop with pneumonia or with an upper respiratory tract infection, TB, after trauma to the chest, pulmonary emboli, or cancers. Unfortunately, the parietal pleura has nerve endings and the visceral pleura does not. So when inflamed, they kind of rub together during respirations and it kind of makes a very, very sharp knife-like pain. It almost feels like a stabbing pain. Clinical manifestations of pleurisy include pain in relation to respiratory movement. Deep breathing, coughing, or sneezing is painful, usually only on one side. You get a pleural friction rub And I think that is a audio pleural friction rub that is hyperlinked. Intercostal tenderness on palpitations, fever, malaise, and increase in white blood cells. By the way, when you get that friction rub, it sounds like you're rubbing the side of a balloon, if you want an example of what it sounds like. Diagnosis could include a chest x-ray, a sputum analysis, and a thoracentesis, where you're necessarily putting a needle into the space, the pleural space, trying to see if there's any fluid buildup in there. Years ago, thoracentesis were just done at the bedside, and we'd put the needle in and you'd let it all drain out. Usually the patient could breathe very, very effectively right after the thoracentesis, but unfortunately, if the underlying cause is not removed, that fluid just rebuilds. With pleurisy, the objective is to treat the cause and relieve the pain. The body produces pleural fluid in small amounts to lubricate the surface of the pleura, and pleural effusion is an abnormal excess collection of that fluid. You would monitor for signs and symptoms, and pain relief is usually the positive outcome of all of this. Nursing assessments would always include to assess the patient's level of pain, observe for signs and symptoms of pleural effusion, and auscultation of the lungs to make sure that there's no associated pneumonias with it. Nursing diagnosis of pleurisy would be an ineffective breathing pattern related to stabbing chest pains. Oftentimes you're going to see, as evidenced by guarding, the patient will hold on to their chest cavity, chest wall, because it's very uncomfortable. Of course, an expected outcome would be respirations are without pain. Nursing interventions include assist the patient to find a comfortable position, pillow propping at times, instruct patient in splinting chest while taking a cough or deep breath. Give them the pillow, hold on to it, then take a cough. Administer or teach self-administration of pain management, heat, muscle relaxation or guided imagery, and evaluate the patient always for hypoxia. And of course, questions will be answered on Monday evening. So please make sure, or Monday day, please make sure you have any questions associated with this lecture.